Hi, everyone. Welcome to the second webcast in our telehealth webcast series. This one will focus on revenue cycle considerations for telehealth, working with organizations to receive payments for the telehealth services you're already providing today. My name is Heather Stillman, and I'm a principal with Citrin Cooperman, and this is a collaborative effort between Citrin Cooperman and Shepherd Mullen. Today, we're going to be covering several topics related to revenue cycle and reimbursement. We'll start with a brief introduction and some background on our firms. We'll go into a revisit of the telehealth maturity model. If you joined our previous webcast, you saw that we had an entire webcast kind of going through the telehealth maturity model. We'll do a very condensed version of that today. Most of our discussion will be focused on the core component revenue cycle with a specific focus on reimbursement. And we'll have a facilitated discussion around the reimbursement implications of telehealth services. And then we'll do a quick wrap up and next steps. So there are a couple of pieces of thought leadership that our firms have gone to market with together over the last couple of weeks and probably months at this point. We've done three different pieces. We've done a telehealth maturity model, and this puts our point of view out in the market that we believe that organizations are going to be building telehealth maturity and capabilities over time as they progress with their technology, their capabilities, their organizational efforts around this. We feel very firmly that telehealth is here to stay, and we're seeing that in the market. But we think that organizations are very appropriately still kind of getting to market with whatever they can today. So our maturity model will provide some more information on that. We also released the first webcast, which was around developing an adaptable telehealth strategy. We feel like organizations need to really think through what their strategy is, how that aligns with their business model, and how they can adapt that over time based on different technologies and different market conditions. And then we also came out with a telehealth readiness assessment, which is a free tool for organizations where you can kind of go on and complete a short survey and determine where you are with your telehealth readiness today. So all of these materials are available on our individual websites, and we will provide some more information on that later in the webcast. I'm going to turn it over to Matt to introduce the Shepherd Mullen team, and then I'll do a quick intro of the Citrin Cooperman team as well.
Thanks, Heather. Thank you all for participating. My name is Matthew Schatz, and I'm a partner at Shepherd Mullen's New York office. And also on the team and participating on the presentation is Erica Kraus, a senior associate out of our DC office. Some just high level background about Shepherd Mullen. We are 900 plus attorneys across 16 offices worldwide. Our healthcare practice consists of 165 plus attorneys. And our services in healthcare run the gamut and cover many, if not all, of the sort of corporate, transactional, regulatory, tax, and telehealth services. In particular with telehealth, we've got significant experience in advising clients on matters relating to governance, regulatory compliance, licensure, and reimbursement. And now, Heather, if you want to introduce the Citrin team.
Thank you. As I mentioned, my name is Heather Stillman, and I'm a principal with Citrin Cooperman. I'm in our healthcare practice, and today Kieran Higgins is going to be joining me. He's a manager. He works very heavily with our healthcare clients as part of our business process outsourcing. Citrin Cooperman, it has a very large presence in the healthcare space. We've got over 700 different clients within healthcare, and we kind of follow the full continuum of care. We've focused in the provider space pretty heavily. We've got clients in post-acute care. We've got clients in health systems and hospitals as well. And of course, provider organizations and physician offices. Our larger firm has about 2,000 members, and we are a nationwide firm as well. We've got offices, our headquarters are in New York, and we've got offices kind of spread out throughout the country. So we've got, we'll talk through some of our telehealth services today, but we also have a full suite of audit, tax, and advisory services. So the next slide and the next couple of slides will go into a little bit more detail around our healthcare telehealth maturity model. And as we mentioned, we have a whole separate webcast around this subject. So we're not going to be going into extreme detail, but if you're interested in that, you should be able to access that on our website as well. But we'll keep it kind of at a high level today. we feel like there are kind of three distinct phases that organizations move through as they are developing their telehealth maturity, starting with initiate and then develop and optimize. And initiate, and then we've got some core competencies that we can talk through in a little bit more detail on the following slides. But the initiate phase, these are organizations that are really just starting with to execute their telehealth program. So they've probably gone to market with some sort of low cost or free solution where they're just trying to get to market and offer services as quickly as possible. Once they reach the develop phase, they've probably started to select a vendor. They're starting to incorporate that into their operations and their financial processes as well. And then when they get past that phase, they move into kind of the optimized phase where it's really part of their overarching strategy. It's not a bolt-on solution anymore. It's part of how they go to market with their services. And what we feel like is organizations, especially because of COVID-19, organizations that perhaps had not fully embraced telehealth before are really trying to get to market as quickly as they can with these services to address the volume loss and really kind of make their businesses sustainable in the future. And we feel like this is going to be a core component and a core capability that they're going to need to have as part of their model moving forward. We feel, again, just to use the phrase, telehealth is here to stay, and we think this will be a foundational element of their future success. So we've got seven core competencies that we have built into this, and these are the areas that we feel like organizations need to really focus as they're building their telehealth maturity. Our last webcast focused on the telehealth strategy component, and today we're going to be focusing on the revenue cycle management component. And each of these has kind of specific both long-term and short-term focus areas that we think organizations can start working on to build maturity over time as they scale and mature their services. So this the first piece, I'm just going to kind of provide a quick overview of the revenue cycle core component because I really want to turn it over to Kieran and Erica to go into more detail. But this is one of the 7 areas that we focused on as we developed our telehealth maturity model. It's the core component definition for revenue cycle as relates to telehealth is the administrative workflow and clinical functions that contribute to the management and collection of revenue from telehealth services, from the initial scheduling through final payment. And kind of as simplistic as that definition sounds, it's a lot of hard work for organizations, especially organizations that are trying to go to market very quickly with these services. We talk to a lot of clients that are really struggling with getting payment for their services that they've deployed in the market. And I think that's what we're hoping today to start talking through some of the things that we've been seeing and how organizations have been able to drive that reimbursement and what they're doing from a front office, middle office, and then kind of back office component. So I won't go through this in a lot of detail because I want to focus on some of the other pieces that as part of the conversation. But as far as the initiate phase as relates to revenue cycle, this is really probably where an organization is still a little bit in crisis mode. They've gone to market quickly with a solution, and they're working on adding the functionality necessary to provide and bill for services very quickly by whatever means necessary. We're seeing a lot of our organizations, especially our physician practices, that are still in this initiate phase. They haven't really been able to kind of turn that corner to start thinking about the develop phase where they're more or less integrating telehealth across their revenue cycle. So they're looking at all the touch points from a revenue cycle and operations standpoint where telehealth impacts their operations. That was where we will see people starting to look as they've kind of been able to reach, when they're able to reach kind of a steady state with their operations. And then once you move past that to the optimized phase, when they're able to kind of think through telehealth as a permanent part of their organization, it's part of their strategy, it's incorporated into their workflows, and they're able to start looking towards getting back to the pre-COVID-19 levels of performance related to revenue cycle in many ways. And of course, they're still going to have reimbursement pieces, and we'll go into some of those, but those are the kind of a brief overview of the different pieces as relates to the maturity model as we're seeing organizations develop maturity and revenue cycle for telehealth services. So just a couple housekeeping disclaimers. This is not, this should not be construed as either legal advice or consulting advice. This is informational, and as we've talked about in our previous webcast, this information changes very quickly, and and we're doing our best as as two organizations to keep up with all the changes. But this is an evolving area of thought. So more to come. But this is not and should not be construed as legal advice or consulting advice. I'll turn it over to Kieran to go into a little bit more detail about the revenue cycle specific impacts of telehealth.
Thank you, Heather, for the the intro. A lot of the work I do is, as Heather mentions, business process outsourcing, and mainly in healthcare components. And what that means is I provide outsourced accounting, finance, and financial operations. So it goes hand in hand with the core components that I'm going to talk about today, which have the greatest impact on revenue cycle management. From a global revenue cycle management perspective, these three core areas, front office, the visit, and the back office, encompass the billing and charge capture life cycle, and the different functions between and how they connect between the three. By virtue, these are the same considerations you would take in your normal day-to-day patient visits if things were in a much different capacity. But they shift quite nicely into telehealth. Beginning in the front office for patient communication, scheduling, confirmation, insurance verification. One good workflow or best practice is scripting. Script the type of exactly what the type of telehealth visit will entail, what it looks like. Your front office, your care coordinator, it will be the biggest driver to make sure you get as much information as possible so that the visit itself goes according to plan. And this goes both ways. Patients don't necessarily fully understand the components of telehealth, whether it's audio only, video, and so on and so forth. So help them, while you're scripting on the front office, and help them understand the differences and what you're going to need from them. What types of services you're going to provide for them and what they're going to receive. And big in, that's going to go in the back offices and the charge capture is timing. You're going to make sure that the time is allotted for on the schedule on the physician side, but also on the patient side, and what options they're going to be using, whether it's a smartphone, and there's a third-party app, or what have you. And that goes hand in hand with how you're scheduling it, and and rolls right into the cost, if possible, and the insurance coverage verification. A good best practice to do is to keep cheat sheets by payer. They're going, as we move into more of a telehealth world, and I think COVID-19 certainly moved the needle on people ramping up the telehealth activities, which vary across subspecialties and practices and systems across the country. With that being said, the needle has still been moved. Taking key considerations from a global perspective, in education, training, templates, workflows, integration technology, or the metrics and measurement, you want to be able to have training capabilities on the website manner, or the abilities, that you're going to need as an organization to deliver care remotely through, whether it's through your EMR, third-party app, or other devices or monitors that your organization might use. And there's an art for providing the good video consultation skills that need to be taught. Just like, providers and staff are taught good bedside manner, in patient interviewing skills, that goes hand in hand in education and training as website manner. Some key elements that organizations may often overlook or not think through in sort of the pre-visit are elements of, video camera, maintain eye contact, and effectively engage patients. And I know all of us have been inundated with these webinars, and we're a lot better than we were in the beginning stages of COVID. So that has evolved. Telemedicine education often, involves hands-on experiences with technologies that make remote care possible, but may not be used in the past. Whether it's a wearable, physicians may use things like electronic stethoscopes, patient exam cameras, or getting into specialty functions like electronic dermatoscopes. So, how you integrate those things, and it is all, in my mind, globally a workflow integration with a technology component, and how you're going to use these various functions across the EMR to a third-party app. And then on the metrics and measurement end, you want to keep to the same functions you typically would track given in a normal visit. The best practices you would, and these are indicative of where you're going to find the lags or lapses between the three. There's days in AR, the claim denial rate, root cause, and I know these are really in a back office function, but these are going to help improve your front office and the actual patient visit. And upfront, if it's insurance verification rate, insurance pre-authorization rate, on the back end, looking at claim submission rate and analyzing the value-based contracts, value-based obligations in the contracts, and that goes hand in hand with some of the scripting and prep work that you want to help your front office and make sure that these items are layered and succinct through the front office, the visit, and the back office. And I know up front, a lot of the work can be done up front as far as what makes the usability of the visit the most streamlined, whether that's documentation templates, taking the time to invest in the IT templates so that the bedside manner for the provider is there, but all of the documentation you're needed is coded, and the coding edits will run through cleanly to the claim, and the back office making sure that they have the capabilities to pull out the information from the template for the bill when they're doing overall coding. And then, as I mentioned before, the payer specific requirements. And I can't speak this enough, how the metrics and measurement is a big core component to key consideration to measure all of these items, and will give you a very good look under the hood of what you need to be doing or implementing in your workflow integration. And with that being said, I'll give it back. I'm going to hand it over to Erica.
Thanks, Kieran. Really, really helpful discussion. And I think as I talk, we'll start to see how all of those types of processes that Kieran was describing are going to help practices as they try to track regulatory changes, coding requirements that go to revenue cycle, and make sure that they're complying with requirements both during and after the COVID-19 pandemic. So my focus here is primarily on Medicare requirements for billing and for coding and telehealth, the reason being that we've seen so many regulatory changes in the Medicare space related to telehealth. But just to keep in mind that every provider has different rules as to each of these components. Those rules have also been changing and in flux during the pandemic and will continue to be in flux as the pandemic subsides. So very important to keep an eye on both what Medicare is doing and what the other payers that you contract with are doing as well. So some general rules for telehealth during the PHE for billing requirements for Medicare. One highly relevant change that we saw actually after Medicare had already gone ahead and dramatically expanded the scope of services that could be provided via telehealth and billed to Medicare was how providers were asked to document the place of service for those visits. Medicare has indicated that providers should use the place of service that would have applied had the service been furnished in person, and providers are to use their best judgment to make that determination. They're not to use place of service 02, which is typically the telehealth place of service. And this actually has reimbursement implications because when you use place of service 02, you get a facility payment rate, which is lower than the non-facility payment rate, which might apply to a lot of telehealth visits that you performed that would have been, say, provided in your office and then billed with a place of service code indicating a physician office visit. So some potentially significant reimbursement implications to using that correct place of service codes, and some challenges for providers who didn't get this guidance until they had already started furnishing and billing for telehealth visits under Medicare's expanded coverage. And I know there were practices that had to go back and rebill. So important to make sure that you're doing that correctly. If you haven't done that correctly in the past, making sure you have processes in place to go back and rebill those services, make sure you're getting the full reimbursement to which you are entitled. Another important rule is that when you're providing services via telehealth during the pandemic, you are to attach modifier 95, and that will indicate that despite the place of service, which isn't the typical telehealth place of service 02, you are providing that service via telehealth, and that's going to allow CMS to track the visits that were provided via telehealth. It doesn't affect reimbursement, but it's important to get that right, because if you perform the service via telehealth and don't attach that modifier, that's a potential false claim and brings its own kinds of liability with that. So important to make sure that you have process in place to make sure that modifier gets on claims for services that were provided via telehealth. And in terms of what Kieran was discussing, very important to make sure that it's being documented in the medical record when a service is provided via telehealth and in a way that can be easily communicated to the back office staff so that they make sure that that modifier is on there when it needs to be on there. The CR modifier, which is a modifier that CMS is requiring on a lot of claims that are provided pursuant to various regulatory waivers that apply during the pandemic, is not required for these telehealth services, even though they are being provided pursuant to a CMS regulatory waiver. So a little confusing, but that is the CMS guidance on the CR modifier. So good to know that one's not required. Not a huge deal if you've been attaching that when it's not required. CMS has indicated that it's better to overuse CR than not to use it enough, but you don't need to be putting those on services that are only relying on the telehealth waivers. The GQ and GO modifiers, to the extent those apply to any of your telehealth services, no, those are limited use modifiers, but if they do apply, you do need to keep using those. Really important point to keep in mind as your telehealth offerings expand is that Medicare is not covering all services that are furnished via telehealth. They're covering a lot more than they used to, but not all of them. And there's a code list where they list all of the services that they will cover. So it's really important to look at that code list and make sure that if you're providing a service via telehealth and you want to bill it to Medicare, that you check that code list and make sure that you see the codes for that service. Many of these codes are temporary additions for the public health emergency, the COVID-19 emergency. So important also to keep an eye on that list as the pandemic subsides. If that PHE ends, it's very possible that those codes will no longer be on the list. So important to be tracking this list and making sure that at any given point in time, the services you're providing via telehealth and billing to Medicare line up with the codes that are covered by Medicare. Another thing that you'll notice on that list, if you take a look at it, and which has been a question that we've seen from lots and lots of providers, is that some codes on that list are designated as being audio-only codes. And these are the codes that you can provide to your patients using just an audio-only phone without a video component, but they're limited. So most codes on the list, you still need to using some kind of video component. It can be a smartphone, but it's got to be some kind of video component. And this is an important point, thinking back to what Kieran was describing with the front office functions, that you'll want to be able to have your front office staff talking with patients about the technology that they need and making sure that they're prepared to engage in that visit with you and to use a video function. Because if you get on the phone with the patient expecting to be able to use a video platform and they're not able to connect via that video platform, you're not going to be able to bill many of these codes if that video never connects. CMS has indicated that if there's just interruptions in the video, the patient's having some trouble, but a lot of the visits provided with video functionality, that can still be okay to bill. But if the video doesn't connect at all, you won't be able to bill that code. So important to make sure that patients are prepared and have the technology they need on the front. And also important to be documenting in the medical record if there are interruptions and the extent of those interruptions so that your back office can make sure that that service can still be appropriately billed under a telehealth code. Also, just to note, the current designations for audio only, most of those only apply during the public health emergency. So also important to keep an eye on that as COVID-19 hopefully again starts to subside and we see changes to those designations and some of those codes returning to requiring video functionality. Important to track that as well to make sure you're complying with requirements to bill. Another big issue that we get a lot of questions about relates to remote supervision. So this has been a big issue for practices who have physicians who, for whatever reasons related to COVID, aren't able to be physically present in an office or with their patients. Sometimes patients aren't able to leave their homes. Sometimes doctors aren't able to leave their homes if they're being quarantined, trying to protect their own safety or the safety of others. CMS has recognized this issue and provided that doctors can provide direct supervision via audio-video tech, and that's a big change. Prior to this change, doctors had to be in an office suite with a patient in order to provide direct supervision. So this is a big and important change, but important to make sure that direct supervision is actually being provided and that that supervision is being documented. So I think this is an area where we can certainly expect some auditing after the pandemic to make sure that when a service is billed incident to a physician's service, that that doctor was meeting the requirements to provide supervision for that incident to billing. And there very well could be good technology solutions to document the physician's availability, that they were signed in, say, to an audio-video platform to make themselves immediately available to provide supervision as needed. But important to be keeping in mind that you need to document that you were providing the required level of supervision. Relatedly, CMS has provided that auxiliary personnel can provide incident to services during the pandemic. So, for instance, a doctor could contract with a home health agency to use their staff to go out into patient homes and perform visits, as long as the doctor is providing that direct supervision. But again, important to have provisions in place, both in the contractual relationship with the home health agency and within your practice, to make sure you're actually providing that required supervision and documenting that you provided it. And with that, I'm going to turn it over to Matt to ask some questions and have a conversation.
Thanks, Erica, and thank you both, Kieran and Erica, for your insights and thoughts. I mean, I think it's really great that we've got the ability to sort of comment and provide perspective on both some of the operational matters as well as some of the legal changes that we are seeing in response to the pandemic. And then also where we think and get your views on where things may be going post the public health emergency period and the pandemic. And just, one thing that comes to mind, you've each mentioned challenges and pitfalls and how those can impact reimbursement. Any sort of one particular or certain issues that you view as sort of being very prevalent among a broader scope of providers or perhaps a broader scope of payer that we're seeing currently, and then we can maybe shift to where do we think we're going to see some challenges and pitfalls on a going forward basis. But just, what are we seeing right now in the market as we address questions and concerns from both clients and customers? Kieran, why don't I throw it to you first?
Thanks, Matt. Appreciate it. And it's a good question. I think particularly in COVID-19, responding and allowing, as we know, many more visits that were historically allowed. I think that the lack of awareness is hurting some of the organizations that I've worked with. That goes hand in hand with just a lack of general understanding of the reimbursement. They're taking on visit types, new telemedicine visit types that they weren't doing before or weren't really in their rollout or platform. And there's a lack of general understanding of what the reimbursement is going to be. So they're getting claims held up, not even getting through the clearinghouse or just getting held up in general in AR and they're lacking the sufficient data to be able to fix that in a timely manner. And things are getting better. As more information, just like with SBA or PPP, then more information is coming out by CMS and OIG, which is helping sort of overcome these challenges, and the service awareness is getting better. And then I joked about before how all our response to technology here, working in a remote environment. I think, I think there was a disconnect between just the general requirements, as Erica mentioned, the patient visit on the technology component, and I'm seeing organizations get better. Patient skills and physician skills are getting better in that component, and then the correct bills or the correct claims can be submitted based on, they're now meeting the requirements per, and with anything, folks are still, the technology component, and it's expensive, as many of us know. And I think the big thing in organizations, another big hurdle that's not necessarily tied to reimbursement, but, general security and HIPAA, guidelines. Everyone wants to, work in this environment. There is a certain level of risk management. You want to be able to cover yourself. So Maybe I want to offboard a little bit there on the reimbursement general, but I've seen a lot of different, challenges, and luckily, we've seen people overcome those challenges more recently.
Yeah, thanks, Kieran. And I think your point about, HIPAA and security is a really good one. We know OCR has sort of allowed for flexibility in allowing providers to use non-HIPAA secure technologies like FaceTime and Skype, but we do anticipate that that will end at some point. And so that's certainly something that goes to the telehealth maturity model with, which Heather outlined earlier, which is right now if we're in that initiate phase, how do we need to sort of move over and shift to the develop and the optimize phase, definitely on the technology piece. Erica, what about from your perspective in terms of challenges? You've mentioned some, but anything else in terms of sort of holistic ones that we're seeing, whether again across payers or specialty, et cetera?
Yeah, so certainly, and Kieran has touched on this, the rapidity of the changes has been challenging for a lot of practices, and also the fact that while CMS has issued a lot of guidance quickly, it's been in a lot of different formats, and it's been sometimes difficult for providers to track all of the different guidance that's coming out of CMS. So questions like, well, I had a video call with a patient, but the video went out for half the call. How do I cope with that? That's not written down in any of the CMS guidance, although CMS has addressed it on phone calls. So very difficult to be tracking all of these different kinds of communications that we're seeing from CMS. As much as we appreciate their efforts to get lots of information out there, it's hard for any practice to know everything that CMS has to say. So important certainly for practices to be working with their advisors and doing the best they can internally to track all of these things and to document their good faith efforts to track all of these things. Another area where we just haven't had great guidance from CMS, certainly, and I think from other payers as well, that's challenging for practices is around how to document these services and how to document compliance with these various requirements, particularly in the Medicare arena, because these services largely weren't covered prior to COVID-19. They were covered in such limited circumstances. CMS has never put a lot of effort into outlining documentation guidelines specific to this area. So providers in many cases are kind of at sea as to what they need to be writing down, how they need to be writing it down, when and what kind of templates they can be using within their EHRs. So a lot of challenges around documentation that CMS hasn't done much to address yet.
Gotcha. Really helpful, Erica. There's so many other questions that I'm sure we can ask and we could sort of drill down into, but I'm also sensitive to time. And so we invite, anyone who's listening or viewing this recording to certainly feel free to reach out to any of us. And there's contact information at the intro slides, but then some contact information at the end as well, which Heather will go over for any specific questions. So Heather, I'll let you wrap.
Thank you, Matt. Yeah. So just to kind of to wrap up and talk through a few next steps, we appreciate everybody participating in our second webinar today. This is part of a series where we're going to be exploring each of the different components of the maturity model in a separate kind of focused discussion. So we're trying to roll them out every week or every 2 weeks, depending on the availability and the ability to get these out and the ability to consume the additional information that's coming out as well. So far we've been able to produce one on the adaptable telehealth strategy. This one's on the revenue cycle, and then we have several more that will be coming out in the coming weeks. But one of the tools that we really want to encourage people to check out if they haven't already is our telehealth readiness assessment. This is a short online assessment that we developed for provider organizations to help them start to think about where they are today in their telehealth journey and where they need to kind of think about building some additional capabilities. And this is, again, a complimentary tool. After you fill it out, our team will take it and analyze the results and provide you a customized summary with some considerations for next steps. So we would encourage you to take a look at that and also reach out to our team if you have specific questions around anything we talked about today or other pieces of information related to the maturity model or just how you're deploying telehealth within your organization. So thank you for your time, and we appreciate you participating.